welcome to Health Smart. I'm Joanne Campbell and I'll be your host tonight. Health Smart is a series of great Health Smart programming brought to you by Hudson Valley Hospital. And every month we have a new guest and a new topic to discuss. This month I'm very excited to introduce Dr. Phillip Calenda, who is an ophthalmologist here. Welcome, Dr. Calenda.
Thank you. Thanks, Joanne.
And so much going on in ophthalmology. To me, it's such an exciting resource for the community to know, how much we can do to help people see at optimum. Tell us a little bit about yourself.
Well, I'm board certified. I've been in private practice for 14 years. Grew up locally in Briarcliff. Still live there. And I'm a member of the Westchester Medical Practice. They're sole ophthalmologist, and provide care to all the people in the community. I do the cataract surgery at Hudson Valley Hospital, and I specialize in a few different things, among them cataract and Lasik surgery.
Okay, so for the people that you're seeing, is there? Do you see people of all ages?
We do. I mean, it's mainly adult patients, but within that group of adults, we see people over a wide range of ages. The Lasik population tends to be younger than, say, the cataract population, but we pretty much run the spectrum. So,
okay, good. Then there's a buzzword. Let's talk about Lasik surgery.
Sure.
What's new, what's happening, and, who can it benefit in our community?
Well, I mean, it's really fantastic where the technology has come in over the dozen or so years that I've been doing it. We went from using blades to make the flap in the cornea to now we've got lasers that do that extremely accurately and safely. And then we have other lasers that are used to actually correct the patient's vision. So pretty much anybody who's nearsighted, farsighted, or has astigmatism, can get corrected with Lasik surgery.
Okay, so that's talking, way to the edges here. So people with corrective lenses could be candidates for having a surgical procedure that would eliminate the need for corrective lenses.
Exactly.
Okay.
Yeah.
And minor downtime, you're saying now you use lasers?
Yep, we use lasers for every part of the procedure. The downtime's minimal. Interestingly enough, I did it on my receptionist about a year ago on a Thursday. She was in the office Fridays working. And,
you run a tight ship.
Yeah, run a tight ship, exactly. And, it's fantastic. I mean, you're back at work the next day, you use a few different drops, and you're seeing just about immediately.
Okay, so that's a call for everybody in our community. Now let's talk about, we were talking about cataract surgery. I mean, again, we have a boomer population.
Sure.
And cataracts are, again, the wonder of surgery is how quickly and efficiently people can have their vision improved. Yeah,
it's really amazing, the technology that's available. And, 30 years ago, people, when they had cataract surgery, they had to lay still afterward for weeks with sandbags on the side of their head. Now we're talking about an incision that is really less than 3 millimeters in size, so it's a minimally invasive kind of procedure. It only takes about a half hour to perform the procedure, and you can take somebody whose vision is all cloudy and is really having difficulty seeing and just basically get rid of that and give them clear vision afterward.
So the cataract, let's talk a little bit about what is a cataract.
Sure.
And because a lot of people say, oh, I got a little fuzz, I got a little this. So maybe we can enlighten people with what actually cataract is and when's a good time to step up.
Sure. And we have this little poster here that demonstrates that very well. This is a normal, healthy eye, and you've got the clear lens in here. And you can see that the light rays just go right back to the back of the eye, the retina, they're in good focus. The person sees the image very well. As we age, gradually the lens gets cloudy as time goes on, and you get to this point where you have, see how it's not really clear anymore, the lens?
Yep.
It's got a yellowish look to it, and you can see how degraded the picture is here. So it tends to blunt the perception of colors, and then even beyond that, just block people's vision from seeing different things. And here you can see the light rays, they don't come to a nice, clean, crisp focus like here. It's just sort of scattered, and it's a very hazy kind of image. And pretty much, if you live long enough, you get cataracts. There's no way around it. But the beauty is, like I said, just having this wonderful technology. The hospital has the most up-to-date equipment. So, it's great being able to take somebody who one day is barely seeing the top of the chart, and a couple of days later, they're reading towards the bottom of it.
So it's a problem with the lens.
Exactly, the lens. It's not a film over the eye or anything like that. It's just strictly the lens is getting harder as people are getting older.
So instead of a disease process, it's kind of like an aging process.
Exactly.
And do you find that people say, oh, I don't see as good as I used to? I mean, what do they really have to compare? Does one eye lens tend to go before the other eye? Do they tend to go together?
They tend to go together for most people, and what's interesting, it's such a gradual process. The average person isn't really aware that it's going on. They'll come in for maybe their yearly exam, and instead of seeing 20/20, now they're seeing 20/30. The next year, maybe they're seeing 20/50. And you really have to point out, oh, you've got this impediment.
Okay.
And what's interesting, we usually do the surgery about 2 weeks apart in terms of both eyes. Once the first cataract's removed, people are amazed at how well they're seeing and what they were missing before. And they're very excited to get the second eye done and just be able to see the world clearly again. It's one of those few cases where we can sort of turn back the clock.
That's awesome. So subjective, objective, like people can't see so well, then they come in for a test, but you can actually see the lens, right? The cloudy lens. I mean, the naked eye, can that see the cloudy lens?
It would have to be a very advanced cataract for somebody to see with the naked eye. But with dilating drops, we get a good view. And what's nice is not only is the cataract surgery itself really cutting edge and very safe and quick surgery, but now we have all these different lens options. Whereas 15 years ago, you got what's called a monofocal lens, which meant you saw well in the distance if you didn't have astigmatism, and you didn't see well up close. Well, now we have lenses that correct all sorts of different problems, so we can really get a lot of people out of glasses or using less glasses after cataract surgery.
Okay. So the surgery is going in and you give me the story, but removing the lens that's cloudy and putting in a new lens that is made of?
Well, they're made of different materials. Basically, they're variations on plastic or acrylic, and what we do is with high-frequency sound waves, it's sort of analogous to if somebody has a kidney stone, we just break it up with sound waves, and it just comes out in extremely small little pieces. And then we just go and insert a lens, and actually this is great for that. You can see here's the cornea. That's where you would put a contact lens on the surface of the eye. So you make a small incision in there, you take the cataract out, and through this small 3mm incision, we put a lens in that's folded and then just opens up within the eye, and this is showing it looking through the iris. I mean, the average person, you don't see this. That's in your eye. You're not aware it's in there. You don't feel it. Nobody looks at you and says, oh, Joanne, what happened? But this gives you a good cartoon version of the steps involved.
Okay, so that lens goes behind, like a contact would go on the outside to correct, but this one goes on the inside and corrects.
Exactly. It goes underneath or behind the iris, and you're not aware it's in there. And nobody can look at you and say that you had anything done. And this chart right here is great talking about which lens we can use. If you go back, like I said, around 15 years ago, if you didn't have any astigmatism, if you were just farsighted or nearsighted and you got cataract surgery, then maybe you could see well in the distance afterward with the monofocal lens. And that's what this shows. But if you had astigmatism, and what astigmatism does is it tends to blur you both distance and near. In this case, where the eye is normal, you got one focus point right on the retina. With astigmatism, you've got a couple of focus points, and then therefore it's blurred.
Okay.
Well, we have what are called toric lenses. They correct astigmatism. And as you can see in this, you'll see well in the distance, and even if you have the astigmatism, you'll now be able to see well in the distance. 15 years ago, that wasn't an option. You wore glasses for distance and near in that case, and you were stuck with that. Now we can correct the astigmatism, and for people who don't have astigmatism but want to see well distance and near, there are what are called these premium lenses like the Restore multifocal lens. That gives people a range of vision. They can see well in the distance, they can see well intermediate and near. They basically, 80% of the time, they're not wearing their glasses, which, you know, is astonishing for people who have been wearing them for many years. So it's exciting.
And that's one lens can do all three of those things?
Yeah, it has special properties to it where it has different focal points built into it. And, you know, it just allows, as the pupil gets bigger or smaller, for people to see distance or near and intermediate.
So like my Verilux multi-level glasses, we can actually put lenses in the eyes that give you the benefit of having multifocal.
Exactly, yep. It's the same thing, and you can see right here, near vision, intermediate, distance. They basically get all of that with that one lens.
And astigmatism, does this come with, is this prepackaged? Does this come with age, or is this something that people have? And what's the incidence of astigmatism?
Well, it's very common. It's usually, it develops while we're going through either childhood or puberty, and then once you're an adult, it's usually pretty stable. It may shift a little bit, but it's really, like I said, childhood, puberty kind of thing. But once you have it, there's no way to correct it unless you know, get glasses or contacts, and now we've got a surgical way to correct it. So, you know, it's very exciting. People are just wearing their glasses for years and years, and now we can eliminate that.
Okay, so those are great surgical options, and as you said, instead of being downtime with 5,000 drops and eye patches and don't bend over, really now with minimally invasive techniques, it's, you know.
Yeah, people can see well, you know, very quickly. Yeah.
Excellent. Okay, now let's talk about general eye health. Other things in your office. I know you're excited because you're kind of the technocrat as well as the surgeon and the medical doctor. Tell us a little bit about the technology that now you're able to use both diagnostically and for interventions in your office.
Sure. Yeah, what's great is we have a wide range of equipment in the office. We've got something called a corneal topography machine, and what that is it basically utilizes the same technology that was utilized by the military in doing topographic maps of the Earth.
Okay.
Well, we've taken that technology and applied it to the cornea, and that's helped us actually in figuring out who's a good candidate for Lasik, who's not, who has some kind of misshapen cornea, how deep is the front part of their eye. So when we're doing cataract surgery, we can take all that into account. It's really exciting technology for, like I said, the surface of the eye, and even if you're thinking about it in terms of this eye model, it really analyzes it all the way back to the lens. So it helps us gather all sorts of information.
So you really see the individual eye at those peel-back levels.
Exactly.
And the topography would be the bumps, the grooves, and the imperfections that would be worth knowing, certainly if you're going to go in surgically, or I guess in any way in correcting the eyesight of the person. Yeah,
it's absolutely necessary for Lasik surgery, and now it's found a home in cataract surgery for the people who are getting these kinds of lenses. We want to make sure if they have astigmatism, it's good, it's regular astigmatism, it's along a certain meridian. That's the kind we can correct. If it was irregular and sort of all over the place, it would be hard to correct. So we've got the technology in my office to figure out who's correctable, who's not correctable, and a whole host of other things.
Okay.
For glaucoma, we've got various machines, which again, you know, a number of years ago, they just weren't there. Glaucoma treatment used to be, what was the pressure in the eye? Here's the drops, and, you know, hope for the best kind of thing. Now we have ways of taking pictures of the eye with our fundus camera, and we follow those over time. It's not a drawing, it's not me remembering what it looked like.
Sure.
It's actual pictures, and we can see, does the optic nerve change in appearance, indicating maybe it's getting worse. We have another machine that actually scans all of the individual little branches of the optic nerve, tells us, are they getting thin due to damage or is it stable? We have another machine where people push a button and it maps out their visual field, so we can see, all right, this person has some early defects from glaucoma. So all those different things allow us to follow people very accurately.
Because glaucoma, unlike cataracts, is a disease entity.
Exactly.
And what's the age and what's the incidence of glaucoma that we're seeing?
Well, most of the cases happen in people over the age of 60, and with each decade of life, the chances of getting glaucoma go up. You do sometimes see it in younger people, so it's good to get a yearly check and just make sure you're not one of those people. And early detection is the key. With a cataract, if we don't catch it early, we can still usually do the surgery, restore the vision. Whereas with glaucoma, once you start losing vision, we can't get that vision back. So early detection and compliance with the drops is key. Something else we have in the office, because there are two different kinds of glaucoma. One is when there's just overproduction of fluid, and the other is when the fluid's just not draining out very well due to an anatomical issue. It's sort of like a clogged drain in a sink. For those people, we have lasers in the office, and with a short laser procedure in the office that takes maybe 5 minutes, we can basically open up that area that's blocked and just allow the fluid to drain out right and, cure it in that sense.
Prevent that pressure buildup?
Exactly, because the people with that angle closure or narrow angle glaucoma, if they're walking around with this and they don't know they have it, they could have an attack and really lose vision permanently in a few hours.
And that's my question. If we're saying that the person with a cataract maybe starts to notice that their vision is not as accurate, acute as it was, with glaucoma, it's more or less make sure you do your annual visits to the eye doctor and make sure you get these tests that are available so that you can help manage the eyesight.
Right, because they probably have no idea whether they have it or they don't. People tend to think, well, I'm seeing well, my eyes must be fine.
Right.
But this is sort of one of those silent things that can be, harming them.
So that's in that annual when somebody puts drops in your eyes, and when you look after the drops dilate you, what are you looking at?
Well, and this is a good example here. You can... Basically, here's the optic nerve feeding into the eye.
Right.
And what we do when we dilate you, the pupil expands and we look right through the iris, right through the lens to the back of your eye at the optic nerve. And if that has certain characteristic appearances, it's suggestive of glaucoma. And then we go on and we do these various tests. Another test that we've done, and this is really exciting, is we have an ultrasound pachymeter. That measures the thickness of your cornea. Because when they first devised how to test people's pressure in their eye, it was based upon people having a certain thickness of cornea. Because you have to apply a certain amount of resistance when you're touching the eye, and then that gives you a reading. If your cornea is very thin or very thick, the numbers are thrown off.
Sure.
So we can just, with ultrasound, measure the actual thickness, and then we put in an adjustment factor, and we accurately know what the pressure is in their eye.
And so glaucoma, the treatment basically is medical management.
Yep.
And medical management is eye drops that control the dysfunction, I guess, to prevent the pressure from causing more damage.
Exactly. Medical is the majority of the treatment for it, and the drops basically either decrease the production of the fluid in the eye or just speed the way the fluid drains out of the eye.
Okay. So again, it's that annual checkup. It's really just make the appointment. And I even have started as I ascend into old age, where you make the appointment for next year, right?
Yeah,
right then,
right.
And you get that card with your name on it that says you actually made this appointment, because like you said, we get so busy, but it's so fundamental, and it's so horrifying if you don't follow through and get good eye care.
Yeah.
Okay, so now we've gone through cataract, Lasik, and glaucoma. It's winter. The heaters are on. You're outside and it's caustically cold.
Right.
Tell me what we're seeing this time of year.
Well, we tend to see a lot of people with dry eyes. And the interesting thing about dry eyes is, depending upon the age range, people get it for different reasons. If you're 20 years old and you wear contact lenses and you're on the computer all day at your job, or you're looking on your iPhone, that's one possible patient who could be developing dry eyes. On the other hand, if you're a 70-year-old woman, due to some hormonal changes, that's another person who could get dry eyes. And there are all different medications for high blood pressure, medications for diabetes, or depression medication that just exacerbate the problem.
Right. And so with dry eye, even though it's coming from different etiologies, is the treatment the same, remoisturize?
Well, what's interesting is the options have really improved a lot over the last 10 years. It used to be that if you had dry eyes and you went to the ophthalmologist, he said, here, use these artificial tears, and that's pretty much the end of it. You hope for the best. Well, now, that's often our first level of treatment, but we can attack it in all different ways depending upon the etiology. We can put them on a drop called Restasis, which actually augments their own tear production and helps the problem a lot in that way. We can decrease the inflammation in their eyelid. So there's a lot of different ways we can attack it. And it's important because, it really impairs people's vision.
Okay, so dry eye, again, shouldn't be just treated as a nuisance. You can try the over-the-counter, but when that's not working, it really behooves people, to make the appointment and come in and have a good check to make sure that you're using the appropriate product, I guess.
Yeah, and dry eyes creates inflammation in the eye, and it can cause things like transient blurring of vision or glare when you're looking at lights, and causes a whole host of problems that are pretty easy to correct if we're on top of things.
But all of a sudden, it is like dry eye is everywhere, and like you're saying, it's our new environment. Pop your contacts in and then, spend all day just trying to focus on something, a screen in front of you.
Yeah.
And that stress is certainly not easy on the eyes.
No, I mean, it's funny. Nobody would ever go to the gym and try and lift weights for 8 or 10 hours straight a day. I mean, you just would never do that. But that's exactly what we're doing with the eyes when you're trying to focus all day up close. So, people need to take breaks, and it's just important that, we're on top of things and making sure our eyes are healthy and not stressing them too much with the dryness.
It's great. Yeah. Okay, and you're part of our Westchester Medical Practice.
Yep.
And where's your office located?
We're right across the street from the hospital. It's 1985 Crompond Road. We're in Building C. It says Cortland Medical Center in the front of the location. Okay.
And besides your eye exams, do you also have glasses and contacts there?
No, we don't sell those.
Okay.
We're really just concentrating on medical and surgical eye care. But, we do take care of, for example, diabetics. We do yearly exams on them, too.
Right. So it's medical management for your eyes because...
You've only got one pair of eyes.
You've got a lot to lose, exactly.
Yeah.
Well, thank you so much for the information.
Sure.
And welcome aboard across the street from the hospital. Again, we'll put that contact number up as we roll through the end of the show. And I really appreciate you coming and talking to us.
All right. Thanks, Joanne.
All righty. Thank you so much for joining us tonight for another exciting program. Health is in your hands, and so we need you to take care of yourself. Check with us next month when we have a new guest and a new topic, and I wish you well.